Our next speaker is Dr. Rejina Mohan. She's consultant retina surgeon at Chaitanya Eye Hospital, Trivandrum. Over to you, ma'am.
Good afternoon. So I'll be discussing some retinal emergencies. So whenever we see some retinal emergencies, the first come in your mind is always arterial occlusion. So arterial occlusion, patient comes with a sudden drop of vision, especially in the range of a hand movements or a PL, without any preceding symptoms. Okay, so high risk history will always be there, like diabetes, hypertension, voltage people, and clinically it is very easy to identify. It's because the daring findings like very whitening of the posterior pole, typical cherry red spot sign, and sometime you may be able to identify some thrombi or emboli within the vessels. Even though I said it is easy to identify, sometimes it may be difficult to identify. In the first picture, you can very easily identify this cherry red spot, but when you look into the second and third picture, it's slightly confusing. And the confusion increases when there is a media opacity. So at this point, OCT is a very easy modality that is available nowadays in every OPD. So first picture, you can see there is a hyperreflectivity in the internal layers. That is very typical of an arterial occlusion, and increased internal reflectivity in the inner layers along with the edema shows that it's a acute occlusion. And as the time goes by, the internal reflectivity will be there, but the edema decreases and later it goes for an atrophy. FFA, always it will clinch the diagnosis, but in an emergency situation we are never going to do an FFA. So this is a BRAO. Here patient may not present with a defective vision, can have 6669 vision. Most common presentation will be a field defect. So in these cases, retinitis or retinochoroiditis is a differential diagnosis, but OCT will help you to find the. So what is the management? If it is here, the golden time, it is always said to be like 4.5 to 6 hours. But what we do in clinical practice, at whatever time, up to 2 to 3 days, we do the same management. Because whatever we have to offer because the patient is in great distress because of the vision. So first is to decrease the IOP so that more blood flows to your eye. Second is ocular massage or paracentesis. Both these two modalities will decrease the IOP. Along with that, it will help to dislodge your thrombi. Other is medical management, either vasodilators or blood vessel stabilizers. So when the patient comes to the OP, patient is in OP, you are diagnosed as ERAO. First thing you do is a ocular massage, either with a direct digital massage or with a gonio lens or with the slit lamp you can do. You can give a tab Diamox or an IV mannitol to decrease the IOP on an emergency basis. You can take the patient to the paracentesis, take for paracentesis in the OT. Never do paracentesis in OPD because there always a chance for endophthalmitis. And after this, you should prescribe some vasodilators and antiplatelets and take your time to describe to the patient about the guardal visual prognosis and ask for a detailed systemic and cardiac workup. Now the second thing is a macula on RT. Okay, so in this case you can see this is a 57-year-old male, myope, post-cataract surgery. He came with floaters actually. So in the first picture you can see when he presented, he had a 6/9 vision. Macula was just on. He had PVD with a little bit vitreous hemorrhage and he was advised for the surgery. Next day, he just came for a preoperative workup and his vision was counting fingers. Okay, you can just see now the macula is off. So, macula on RDs are emergency, especially if it is a superior RD. Next situations are viral retinitis, especially when patients who have history of uh, diabetes, on chemotherapy, transplant patients on Vislon, presents with a retinitis kind of picture, you should always suspect viral retinitis and start your treatment. Okay, so we have different antiviral agents like ganciclovir is there, acyclovir is there, but the valganciclovir, it is easy to administer because initially its dosage is BD and after 3 weeks you can make it OD. But if the patient is not giving a systemic history, then also you can start antivirals. Then you ask for a systemic workup to find out whether what is going wrong with the immune system of the patient. So this is after 1 month of valgal encyclovid, patient who came with the hand movements got stabilized with a CF 1 meter and 660. And now come to severe postoperative inflammations. So whenever there is a severe postoperative inflammation, our confusion is always between a TAS and an endophthalmitis. So whenever it comes very early, next day itself, lot of fibrin, less likely hypopion and recent good vision, congestion is less, you think of a TAS. Whereas if it is very severe, painful, congestion, lot of hypopion, you think of endophthalmitis. And here one thing you have to remember is, in the first sitting itself, you should always take a B scan, because it will document your vitreous echoes and will help to assess the progression. And if there is lot of vitreous echo suggestive of vitritis, you should always think in terms of endophthalmitis. And whenever you are in doubt, treat it as endophthalmitis. Okay, so how to start? Start with the topical antibiotics. You can even start with moxifloxacin. But if there is severe inflammation, start with fortified drops. Next is whether systemic antibiotic, it's slightly debatable, but always good to start. And first sitting itself, always go for a vitreous tab, send it for culture sensitivity and gram stain, and give a broad spectrum antibiotic. Repeat the injections after 48 hours. And repeated injection should contain specific antibiotic according to your culture and sensitivity report. But what if your culture and sensitivity report is negative? You can always go for a PCR. Okay. In our institute, since we have an in-house PCR setup, we first sitting itself we ask for a PCR. And whenever the vitritis is worsening, vision is coming down, you can opt for a vitrectomy. Next is endogenous endophthalmitis. Here the infection comes from your bloodstream. So the management is basically targeted towards the systemic foci of infection. The initial documentation should be done with a B scan and OCT, but you should have a very detailed systemic evaluation with blood culture and urine culture. You can take vitreous tab for culture also along with intravitreal antibiotics. Even though the main treatment is for the systemic infection, whenever the intravitreal exudates are going high, you can opt for vitrectomy. And the last one, always an emergency trauma. So in blunt trauma, we know there are a lot of retinal changes in blunt trauma, but one thing you should never miss a peripheral retinal break and small RDs, because 80 to 85% of the peripheral breaks in a post-traumatic case can develop into RD. So do a detailed fundus examination with the peripheral IO, identify the breaks and do barrage as soon as possible. And whenever you suspect occult rupture, you know all the findings of an occult rupture, do a very gentle B scan, find out any disruption of the scleral coat, and if you have any suspicion, always go for a controlled exploration with suturing. And open globe injuries, you may not be able to say what are there in the posterior segment, and never do a B scan in an open globe injury in the primary sitting. Your primary mode of investigation is a CT orbit. Okay, then you go for a primary repair and aim for a watertight suturing. If there is intraocular foreign body is there, your view is clear, you can always and you should always remove the intraocular foreign body in the first sitting itself. But if the view is not clear, globe is not stable, you can wait for the primary suture, let the globe stabilize, then go for a foreign body removal. And when should you suspect a post-traumatic endophthalmitis? When there is hypopion, severe clinical symptoms even after your initial treatment, pain is out of proportion to the injury, you should suspect endophthalmitis. And you should start with the regular endophthalmitis treatment like topical fortified drops, systemic antibiotics, and with severe vitritis, IOFB and RD, you can always opt for a vitrectomy. Okay, thank you.
Thank you, ma'am, for that wonderful talk. It was short and crisp and very informative on management of